Does 189 or even 021G for that matter answer the clinically relevant question? So these are patients, all PD-L1 expressors, being randomized to carbo-pem versus carbo-pem-pem. The greater than 50%, which I assume will be about a third in each arm, the control arm is carbo-pem, not PEM. And so it really doesn't answer a question for me. I assume the greater than 50% are going to do better with a regimen with PEM than a regimen without PEM. And then the less than 50% is the group that I'm really interested in seeing something, whether that will really be powered to show survival differences. I think they're going to look at this. But does this answer the question? Will 189 lead us down a road of conclusion in what to do?
Well, again, we don't know at this point. I think those are really good questions that all of us are asking. And again, as I said, is the overall survival in 189 driven entirely by one particular group based on PD-L1 level of expression? And I don't know. No. Is it possible that we're going to get mutational burden analysis as part of 189? And that would be a better, clarifying sort of biomarker as to what to do with this patient population. But we simply don't have the data. However, I would argue that if you have a young patient with good performance status with huge tumor burden sitting in front of you today in the clinic without an EGFR, without an ALK, and you're looking at data that says with the triple combination you have a 55% response rate versus your usual 30%, it is hard to argue that you should not use the triple combination because you don't have the subgroup analysis done, right? So I think when you're making the day-to-day clinical decision, based on what we have now, as imperfect as it is, you have to consider the triple combination as a potential option for somebody who needs it. Now, I would not give the triple combination to somebody that I know has a PD-L1 expression of 50% or higher.
You would not?
No, I would say clearly in that patient, based on everything that we just discussed, 3-year median survival with follow-up. Why do I need to bring the cytotoxics into it?
Even if they're a never smoker?
Well, again, that's not, the population that we necessarily have the data, but sure, if they don't have an EGFR or an ALK, they have 50% or higher.
You're giving them single agent.
I would definitely give them single agent.
Even in the 50% group, 55% did not respond, 45% responded. So you treat someone with PD-1 alone, you give a few cycles, they're starting to grow. Do you add chemotherapy in then?
Well, that's the subject of a study that we've proposed to do as part of the NCI cooperative groups. We don't have the answer to that. But if I look at the cohort G data and now Keynote 189 and maybe even Empower, I can make an argument reasonably that maybe I try 2 cycles with the combination and see if I get a better response out of that patient. So I don't think it negates it if you started with the IO alone and you don't get the desired effect that you should not or cannot add the chemotherapy. What other options do you have in that patient except going back to your traditional platinum doublet where you know the response rate is getting 20, 30%?
No, I agree. The way I'm looking at these data, even before 189 came out, is certainly I'm very clinical trial focused, as I think we all are. But in the real world, you don't always have a clinical trial, although it would be nice if we did. But if someone is PD-L1 high, I agree. Give them pembrolizumab. Although if they're symptomatic, you can make a case for giving them the combo. But if someone's low, in the absence of a trial, I'm using the combo. Again, it's only for the non-squamous because, again, I've been doing this a long time.
For all patients, Roy, any patient who walks in with less than 50%, you're generally offering the triplet therapy?
Well, first we look at one of the 10 different trials we have and we try to figure it out. Of course, doing the cooperative group trials first.
Yes, thank you.
However, if the patient doesn't qualify, the only patients I've seen with metastatic lung cancer, absent a driver, actually even with a driver, that have lived long-term, 2, 3, 4 years, have gotten a PD-1 or PD-L1 inhibitor. So my philosophy is get that into them as quickly as possible.
More like a one shot on goal, get all active.
Exactly, you might not have a chance for a second line. So I think that the Keynote 21, albeit small, gave us that hint. But now with 189, even without the data, and that data will be out there pretty soon, I'm betting, I think that just confirms they hit their endpoints, they saw survival. So I would use it, and I do use it when I don't have a trial.
Right, and I think this is an area where consensus is still emerging. It's clear that from these trials, we look at non-small cell lung cancer patients without a driver mutation in 3 different contexts: the high PD-L1 group, the low PD-L1, and the absent PD-L1 group. And each of these trials that are going to read out, we have to look at each specific subset and see how they did. And I think that's where we're going to learn the definitive answers. I agree with Roy that if you had a low PD-L1 patient and the patient was having very aggressive disease and you thought that the patient is only going to have one shot at treatment, then you want to give them the 3-drug combination. In my clinic, if they don't fit into that category, I still start with platinum doublet and then go to second-line checkpoint inhibition.
And that's been my practice, and I don't know if we have a right answer here, but I think if they're less than 50%, if they're symptomatic or they have a heavy smoking history, not that that's the, albeit, best clinical enrichment factor, I would probably start with a platinum doublet and then sequence them to immunotherapy. You could make the argument, however, that they may never see an immunotherapy agent if you do it that way. So I think there's a lot that we can learn over the next 6 to 12 months. I'll be very interested to see the subset analysis from 189 for the less than 50. Now, I don't know if that will be powered for overall survival or PFS, but I'll be very interested to see what that
But
shows.
that's going to be, again, the discussion. If it's not powered, are you still going to avoid using the triple combination in low expressors?
Depends on the trends. Even if you don't have a strong p-value, if you see the curves separate and stay separated, you would use them.
Tom, in your practice, approach to using this in all patients, symptomatic patients?
So I segregate them. The PD-L1 highs, I generally give single-agent pembrolizumab. Generally the one below 50, I do carbo-pem, pembrolizumab for the borderline performance status, symptomatic. For the people who I think I have one opportunity. The place I use carbo-pem alone is generally the people with no PD-L1 expression, never smokers, and I think there's a sort of a debate about how much incremental value there is in adding immunotherapy. Granted, that's more my own personal bias than evidence-based medicine, like we've kind of talked about.
Yeah, we all have
we
our
just
own
don't have
evidence.
evidence.
We make it ourselves.
Oh, we call it bias. We don't call it evidence anymore. It's personal.
So it's a lot of confusion there. I think that we'll find out a lot more very soon. And I don't know if we'll still have a right answer. And I think treatment decisions will still have to be individualized.
But every study, no matter how well designed it is, you know, it leads to some answers and it leaves you some questions that you still have to answer for the subsequent studies. And I think that's where we're heading. And we have to figure out what to do with the other populations.